Assalamu alaikum, and good evening to all of you in United Arab Emirates. And I would like to thank our course organizers for inviting me to speak in the 10th annual Neonatology conference, the hottest topics in Abu Dhabi. I especially like to congratulate Drs. Khan and Dr. Rahmani for this being their 10th year of this wonderful conference that the Children's National Hospital has been able to be engaged with. We so much appreciate being part of this special conference every year. I'm a little bit sad, and I'm sure Dr. Khan and Dr. Rahmani are, in that this was the year in which I had promised that I would come and speak in a Candora. And because I'm not there live and in person, my Candora will have to wait until the next meeting. What I've been asked to speak with or speak about today is about the new guidelines for pulse oximetry screening for critical congenital heart disease. During this talk, I'm going to track the screening program from concept to policy. I'm then going to tell you a little bit about the new recommended simplifications to the screening algorithm. I'm going to discuss some current global needs and challenges around screening and talk about opportunities for improving global congenital heart disease care. Pulse oximetry screening began as a concept in 2002 with this article by Hoke. This was a group of investigators from Johns Hopkins University who showed that performing routine pulse oximetry in the nursery added to their ability to capture all babies in their nursery prior to discharge with critical congenital heart disease. Their paper was followed by a paper in Florida and in Long Island that also showed practical benefit to adding pulse oximetry screening. Unfortunately, for probably the next 8 or 9 years, the United States effort was lacking. Research really moved to Europe, in particular the Scandinavian countries, where some key articles identifying the problems around failed detection, the ability of pulse oximetry to add to the identification, and the sensitivity and specificity of screening really came to bear. On the basis of this strong European literature, the Secretary's Advisory Committee began to investigate pulse oximetry. We had the first expert panel that met in Washington, D.C., where we devised an algorithm for the United States. That paper was published in Pediatrics, and within a year of that manuscript, we were able to receive endorsement from Health and Human Services to add pulse oximetry screening to the newborn panel in the United States. But more importantly, we also got all of the major scientific societies to endorse pulse oximetry screening. Since then, a lot of work has continued. This is a Cochrane analysis that was published by Andy Uhr's group, and Andy and his group looked at all of the major studies in pulse oximetry where one could accurately assess sensitivity and specificity. And as shown here, one can see from a ROC curve that pulse oximetry operates in an area of moderate sensitivity and very high specificity, nearly 1. So again, this is a very sensitive test, but even better than that, it is a test with high specificity. That is reasonably able to capture all of the conditions and very few false positives. And this is a listing of some of the papers from around the world that Andy's group used in their Cochrane analysis. Following the US recommendations, we were able to work with a group of European experts led by Paolo Manzoni. And I was very pleased to see that Paolo was giving one of the opening talks in this meeting. Paolo is not only an infectious disease expert, but a world-renowned neonatologist, and he was able to bring together members of each of the major scientific organizations in Europe to this group of experts, and we were able to generate a statement for the EU. And essentially, we did recommend that all European countries adopt pulse oximetry screening, that they use motion-tolerant new generation equipment. Unlike the US, the European model was going to recommend screening after 6 hours and before 24 hours of birth. Like the US model, they did recommend screening both the hand and the foot. Now, what has happened since then? Well, since then, we've been able to start to see the benefits of screening. This is a paper by a book working with Matt Oster, a colleague of mine, in which they and their colleagues at the Centers for Disease Control looked at the association between state implementation and early infant cardiac deaths. And what they were able to show is that states with a mandatory policy, here in the yellow, had lower morbidity, lower mortality from the beginning. And over time, as they implemented pulse oximetry screening, they had a further reduction in infant mortality. In comparison to states that had either no policy or a mandatory policy that hadn't been begun, or a non-mandatory policy, these states all had higher mortality and showed no improvement over the time period. It's quite impressive when you look at the results in those states with mandatory policy. There was a 33% reduction in deaths between infants with critical congenital heart disease between 1 day of age and 6 months of age. Surprisingly, there was an additional benefit for children with other or unspecified congenital heart disease, where they had a 21% decrease in mortality. Things have not changed between what we consider the core critical congenital heart defects and the secondary conditions. As was initially shown by Anne Granelli in Sweden, not only are we able to detect the critical congenital heart defects, but many other secondary conditions that are important: hypothermia, infections, sepsis, lung disease, persistent pulmonary hypertension, which were originally called false positives, but now we like to refer to them as secondary conditions. Now, it is still impossible to pick a perfect algorithm. Of course, looking at the ROC curve, a perfect algorithm would occur up here with 100% or a sensitivity of 1 and a perfect specificity or a false positive rate of 0. That would be our best situation. And unfortunately, there is no test that performs in that way. But as shown here in this green with the red dot is where the Cochrane analysis puts the sensitivity and specificity, and in the green circle are the ranges of sensitivity and specificity from the major studies. In other words, it is not a perfect test. There are some false negatives, but the number of false positives are exceedingly low. In 2018, after we saw the results of Matt Oster's paper in the CDC and the improvement in mortality, we decided to have an additional stakeholder meeting. These individuals represent all the major scientific societies in the United States. They also represent governmental organizations that have a a stake in CCHD screening. Our NIH, FDA, CDC, HHS, all represented. And what we wanted to do is to see if we could improve the protocol at all, or to see if there were other things that we might consider moving forward with pulse oximetry screening. The first thing we did is we looked at the various protocols shown in this top chart. The pediatrics one here, 2 extremities, 95 pulse oximetry in either the upper or lower, a difference of less than or equal to 3 for a pass, 2 rescreens, and screening after 24 hours. Compared with New Jersey, that went to 95 in both extremities, a little bit of higher bar to pass, whereas everything else was the same. Tennessee simplified it. They said, we don't think you need to do 2 extremities. They only screen the foot, but they want the foot to be at least 97 for a pass. And they really don't go and repeat just the foot. If you fail that first screen, they then move to the American Academy of Pediatrics protocol of doing 2 extremity before failing a baby. Granelli, much closer to the US. You're a little bit more restrictive in that you can only have less than or equal to 2 difference between the upper and lower extremity. And like Poland and Germany, Andy and his group have eliminated the second rescreen. Now, the issue with all of these is because of the numbers, it's hard to pick the best one. And it's hard to really say with any kind of certainty whether one of these is better given this sensitivity that you're seeing. How about, is there a best time to screen? Well, we do know earlier timing increases the number of test positives and thus the risk of more false positives. Now, Andy Ewer has pointed out in their experience, not all test positives need an echo. And in fact, in his experience, only about 29% of babies that test positive move on to an echo because they, with some certainty, have been able to find other explanations for the child's failing pulse oximetry screen, whether it's infection or PPHN, TTN. They're able to find those babies, get them into treatment, and avoid the cardiac testing. What we do know, though, is because those are considered false positives, that Europe has a higher false positive rate of 0.5 compared with the US, which is 0.05. For that bump in false positive rate, though, they do have a better sensitivity. The sensitivity in Andy's group is 84, compared with most of the US studies at about 77. Andy points out, and it's an important point, that the earlier timing may catch babies before symptoms develop. And in his experience, 50% of babies develop symptoms before testing after 24 hours of age. So many of the babies are already symptomatic and may even miss their pulse oximetry screening and go into a evaluation and treatment mode. So let's talk about measuring these screening tests. Now let's talk about test positives. So if you're a test positive, you could be a true positive or a false positive. Obviously, true positives we're not too worried about. That's our goal. But these false positives, I don't think they're really an issue. And if you look at specificity in nearly all the studies, it is very close to 100%. And if you look at each of these studies, again, 28 to 79% of the false positives had other pathology found. Look with a little more detail at Andy's data with 26,000 births almost. They screened at a mean age of around 7 hours. Most were after 12 hours. They had 208 test positives, or about 8 per 1,000 live births. And critical congenital heart disease was found in 17, or about 8% of those babies. He does note that they did miss 2 babies with critical heart disease. What about those test positives? If you look at the test positives, 21% were really true false positives. They had no disease. 8% were congenital heart disease, and the other 71% were babies with secondary conditions that one wanted to know about. And he goes on to say that since putting in pulse oximetry screening, they've had no baby collapse in the postnatal ward. What about test negatives? So here's the rub. A test negative can be a false negative, or it can be a true negative. We're not going to worry about true negatives because they're going to go on and get normal care. The false negatives have been shown in multiple studies, starting with Gurnelli's, to be really the left heart obstructive conditions, coarc, interrupted aortic arch, and some babies with acyanotic tetralogy of Fallot. This is a cartoon from Dr. Rudolph's textbook, and this is actually a baby with saturations filled in from the newborn screening. This baby had 96% saturations in the upper and lower extremities. And as you can see, this baby has the substrate for coarctation of the aorta. There's isthmic narrowing. There's already some indentation with some mild ductal constriction. But because the ductus arteriosus is still moderately patent, there is still unrestricted flow to the lower extremity. The ductus is predominantly left to right, and the child has normal saturations. But what happens as time goes by? The baby's discharged, and over the next several days, as the ductus begins to further constrict, it results in a further worsening of the coarctation, so that this child now is going to be symptomatic. This is disease in progress. And if that ductus is still there, and it was on admission to our intensive care unit, the ductus is going to reverse shunting. It's going to go right to left because the baby's left atrial pressure and pulmonary artery pressure are going to go up. And this baby, on admission, had a failing test because now the anatomy had changed and altered, and as such, the physiology allowed the pulse oximetry to identify it. What we did with our stakeholder meeting in 2018 is to look at the conditions that one might think have the highest sensitivity in an effort to let neonatologists and pediatricians know which of the conditions that they probably will catch, they may catch medium sensitivity, or are likely to miss low sensitivity. And again, the low sensitivity, the acyanotic tetralogy, the coarctation that's evolving, Epstein's, which may have varying degrees of severity and may not be cyanotic, and interrupted aortic arch. And also double outlet right ventricle, triatresia, and critical aortic stenosis, which all around the time of testing may have a patent ductus arteriosus that hides the abnormal physiology. So at this stakeholder meeting, we considered 5 questions, 5 potential changes to the algorithm. These are the 5 questions we asked. We then had our audience, after scientific evidence presented, vote whether they would recommend these changes or recommend them. The 2 things that our experts felt could be changed was changing the lower limit of saturation to 95% for both the pre and post-ductal measurements. This will result in a little bit higher sensitivity. It may cause a few more false positives, but our feeling was at this point in time, the evidence showed that those false positives were not significant. And we also felt that the algorithm was confusing by having a saturation difference between the upper and lower extremity for passing. So this simplifies, and we hope will avoid errors in interpretation of the results. We also voted for eliminating the second retest. And I'll show you a little bit of that information. We did not recommend screening just the lower extremity. We did not recommend the UK post and pre-ductal differential saturation of 2%, and we did not feel that we are ready to begin screening in the first 24 hours of life. This is data that helped us eliminate the second rescreen. This is from Matt Oster, and it's babies born in the metropolitan Atlanta area. There were over 77,000. 99% passed their pulse oximetry screen. 18 failed right away for pulse oximetry less than 90%, and 16 failed after 3 tests. That's 34 total failures. Of those, there was a baby with critical congenital heart disease and 10 with non-critical congenital heart disease. And there were, the rest were conditions otherwise specified as the sepsis, TTN, and some true false positives. Now, what Matt asked was what happens if we simplified and went to this protocol at the bottom, which is only one retest. And what he showed is that eliminating the second repeat screen marginally increased the false positive rate to 0.054 without really changing the false negative screenings. And I think this really shows it best here. If you take the initial screen, 77,000 babies, the majority pass, 18 failed straight away. Of those that needed a repeat screen, 149 passed on the first repeat, with only 25 needing another screen, of which 16 passed on the final screen. So all in all, there was not a tremendous number more that ended up with being test positive. The other way of looking at this is that with the original algorithm, there were 34 total positive babies. And by eliminating that repeat screen, that went to a total positive of 43. And again, sensitivity didn't change, but the false positive rate went up from 0.04 to 0.05. And that's where we have now come up with this algorithm with only the original screen and only one retest. If you're wondering about how to do this or further details, I would direct you to the publication in Pediatrics. One of the nice things they have as part of the AAP publications is a video abstract, which also demonstrates this revision quite nicely. Our expert panel thought there was a case for improving education, not only in the United States, but around the world. What we found in a survey that was done with our colleagues at Harvard UCLA Medical Center was that about 51% of hospitals identified that they were not able to always follow the recommendation for a failed screen. We also found that protocol adherence in these hospitals was quite variable. So from our original publications to now, we have the sense that a number of hospitals are deviating from the recommendations, and which is going to create problems with standardization and proper evaluation of this screening test. We want to remind folks that if you do fail pulse oximetry, timely referral for cardiac evaluation is important, in addition to considering the other possibilities as sepsis and respiratory issues. Now we're going to move on to the issue of global CCHD screening. It's been amazing the progress we've made in getting recommendations for screening around the world. The parts of the world that have recommended screening are shown in purple. Recommended screening doesn't mean everyone is being screened, but there is at least a recommendation to screen. The gold or yellow areas are areas in which there are multi-center studies. Blue, interest in screening, and gray, where we don't know what's happening. There's been a tremendous amount of publications: Bosnia, Paraguay, Europe, Denmark, Italy, China, India, Pakistan, Thailand, Saudi Arabia, Sri Lanka, Sydney, Australia, Turkey, and Spain, where benefit has been shown from pulse oximetry screening. This is a picture from a 2019 workshop in Rabat, where we were able to go to a meeting endorsed by the Moroccan Ministry of Health. We had 140 participants from 20 countries from the MENA region, and we were there to provide a 4-hour workshop devoted to CCHD screening. During that workshop, our collaborators at the Morocco Marrakesh Mohammed VI University Hospital presented their 10-month pilot data from the largest maternity ward in Morocco, and I think one of the largest in Africa itself. And they screened 8,000 babies during that time period, most of them under 24 hours age. And of those, the majority passed. They had 15 failures, or about 1.8 failure per 1,000 live births. The majority of the failures had congenital heart disease, 10 out of the 15. 5 of them, the so-called false positives, 3 of which had other pathology, and only 2 that were normal. And they really felt that pulse oximetry added benefit to their patient population in Morocco. This is a study from Thailand where essentially the results are very similar to United States. They used the US protocol. They looked at 11,000 newborns, and they found sensitivity and specificity that was high for pulse oximetry screening. Here are the results. Pulse oximetry sensitivity 82%. When added to the physical exam, it went up to 99%. Australia and New Zealand, even though they do not have a country recommendation, a survey of the hospitals revealed that 77% of the hospitals are screening in Australia and New Zealand, quite impressive. China now has a national recommendation to screen, and 28 out of 31 provinces are screening. In 2019 alone, they screened 2 million babies. And by their report, they found 9,451 infants with congenital heart disease. Now, I want to talk a little bit before we end on disparity in congenital heart disease. This is information adopted from the United Nations Sustainable Development Goals in 2016. Those goals are looking to reduce mortality in neonates to less than 12 per 1,000 births and reduce the mortality of children to less than 25 per 1,000 live births. They want to reduce premature mortality due to non-communicable diseases by 1/3 by 2030. And the issue is, this is going to be a failure. Congenital heart disease accounts for 1/3 of the birth defects occurring in children. And 90% of children with congenital heart disease are born in locations with little to no care options. How will we reduce mortality without addressing congenital heart disease in the developing world? We worked with the IHME, it's a group in Seattle, to really try to take their global burden of disease model and modify it for congenital heart disease. This slide here shows the death rate per 100,000 in a population for congenital heart disease under a year of age. Here in the red are the high SDI countries, high socioeconomic countries. The high countries in 1990 had already achieved a low mortality. And over the last 26 years, that mortality has continued to improve. Here in the orange are the low socioeconomic countries. They have a high baseline mortality in 1990. And look, over this time period of 26 years, there has been no improvement. And looking even at the middle SDI countries or high middle SDI countries, their mortality is still high and the improvement not as great as with the high socioeconomic countries. What does that mean? Well, let's look again at the high SDI countries. If you look at the congenital heart disease as a percentage of deaths, back in 1990, congenital heart disease accounted for about 12% of deaths in children under a year of age. That has dropped by a third to 9%. Look at all the other countries. Here's the globe. So just global. The rate was about 3%. And it has, if anything, risen. Look at the high middle, a rising proportion of deaths in children under a year of age from congenital heart disease. The other way of saying it is that if you look at all the reasons why children die in the first year of life, this is just in the low socioeconomic countries. Again, a lot of prematurity, infectious diseases, birth trauma, infections again, hunger, sepsis, okay? With improvements in water and maternal education, a lot of these conditions are decreasing in significance. But congenital heart disease, which was the 13th most common cause of death, has risen to the 8th most common cause of death. The other way and final way of looking at it is years of life lost. About 6 years ago, I was at the WHO offices representing cardiologists from the United States at a NCD meeting where they were looking at how to decrease death from heart disease in the world. And the focus, I can tell you, was all on adult conditions, predominantly atherosclerotic heart disease and stroke. This slide shows the years of life loss over here from congenital heart disease in purple, compared with the years of life lost from ischemic heart disease, hypertensive heart disease, stroke, and congenital heart disease. Hands down is the most common cause of years of life lost than all of the other types of heart disease combined. The United Nations, the World Health Organization, will make no improvements in mortality in under a year or childhood until they address the global disparity within congenital heart disease. Finally, I'd like to thank my collaborators my collaborators at my hospital and at Children's National, my international collaborators. Paulo, it's great to have you here on this, the 10th Hottest Topics meeting. And I again want to congratulate Dr. Khan, Dr. Rahmani, and the Mina and Saha teams for their commitment to this wonderful lecture. I'm so sorry I'm not going to be there. Inshallah, the 11th annual. Thank you very much. Shukran and good night.